دكتور سامي كيفك؟
تمام.
كيفك خالد؟ معك خالد.
أهلا خالد، أهلين.
Dr. Sami, you are muted. Dr. Sami, you are muted.
Good afternoon. We are happy really that we have this number of registers to our ABC Oncology educational courses. And on behalf of CRG, the President Dr. Fadi Farahat and AMAC, we are welcoming all of you to our activity, which will be about updates in diffuse large B-cell lymphoma and multiple myeloma. It's our pleasure to present our panelists. You know, our first panelist, Dr. Jen Sheikh, is Associate Professor of Clinical Medicine at the American University of Beirut, Lebanon, and Dr. Nabil Shamsuddin, a Professor or Clinical Medicine, Hematology, and Oncology at Medical School University of Belmont, and Associate Professor of Medical Oncology at Medical School St. Joseph University in Lebanon, and Dr. Ahmed Ibrahim. I will let the floor to Dr. Jain to present our first speaker, knowing that the lecture is recorded, and will announce as usual that our activity is endorsed by AMAC, UICC, and ASCO, and awarded by 2 CMEs. Please, Dr.
My pleasure to present Dr. Nabil Shamsuddin as Sami, our friend, Professor of Clinical Medicine, University of Belmont, and St. George University. Dr. Shamsuddin, we talk today about the biosimilar and non-Hodgkin lymphoma, investing in health and access. The presentation is not live, so you can send any question to the panelists on the chat or maybe at the end of the presentation. We can start the video of Dr. Shamsuddin, please.
Okay. And good evening. I am Dr. Nabil Shamsuddin. I am oncologist, specialist in mainly in hematology oncology, and it's a pleasure to me to participate in this small conference, but very interesting conference about update Hodgkin lymphoma and multiple myeloma. My talk will be mostly as economically and to validate what medicine less expensive and as effective as the more expensive medicine. It's the subject of biosimilars, and it is a time to Lebanon to convince our community and our political, economical leaders that biosimilars must be the first drug to be chosen in the treatment of our patient. I will talk about Rixathon, and it is I have to thank also Sandoz, which is the fabricant of the Rixathon. Rixathon is the biosimilar of rituximab, and I will try to prove to you that it is as effective and at least not less effective than the originator, which is the Mabtera. Yes. So Sandoz and Novartis have cutting-edge biologics development and manufacturing facilities. You know, Sandoz, it's very old pharma line, and Novartis has acquired, I don't know the exact mechanism, but they are the one single now pharma producing many generics and biosimilars, and it's implanted in the north of the Europe and in north of America. And Sandoz is a pioneer and global leader in biosimilars, 70 years of biotechnology expertise, over 500 million patient days of experience, 7 Sandoz biological approved in Lebanon, and available in almost 100 countries. And you have the available biologics, biosimilars, or all these, or biosimilars, I think, yes, or also some generics also. But you have here the Omnitrop, the somatropin, you have Zarzio, the GCSF, the Rixathon, the anti-CD20 monoclonal antibody, Linoclid, the erythropoietin, and etanercept and adalimumab used in mostly in rheumatic disease. And have here the timeline of the development of this biosimilars, and the first biosimilar has started development in the 1996, and you have to wait 2006, 10 years after, to have the somatotropin, and then you have the listing, you have the erythropoietin, you have the somatotropin approved in Japan and in European Union, you have the filgrastim approved in US, you have the rituximab also, and etanercept, and launched in Europe, and 1 year after, which is very good, it was approved in Lebanon. So we are active in Lebanon. Sandoz is active. It's has approved rituximab and adalimumab in Lebanon in 2019. Biologics products made using or derived from living organisms in biotechnology. So there is a big difference between chemistry and only chemistry, physicochemistry drugs, and the biologics drugs. The biologics you have now, we are talking about cells, about living cells. We know many, we have a great knowledge about biology, but we have also many unknown details in the biology of a human living. So why it's more difficult, of course, to have a biosimilars, to have a product produced by living cells, but with a very good rules of analytic test, we can be sure that our biosimilar, the drug produced by this living cells, will be as at least similar and at least as effective as the originator produced by another firm. So the reference biologics, or the originator, used as reference product to develop the biosimilars. And biosimilars here we will talk about Rixathon, can be marketed once the relevant patents of the reference biological have expired. It is not a copy. We are legal. We have to have the details of the manufacturing of the originator to be sure that our biosimilar is highly similar to the originator. If we don't wait for the patency, so it will be a copy, and we don't have the fine details of the biological process of the originator. So the EMA defined the biosimilar, the FDA defined the biosimilar. It's very the same. The two ruler have the same definition, highly similar to biological reference medicine. It must be safe, effective, efficacious, and to apply to say that it is a biosimilar. It's the same also, instead of efficacy, we say potency. You add your purity, but it is also in the pharmaceutical qualities that the purity is assured by the FDA and safety. So the generic, the small molecule generic, where only chemistry is within the manufacturing of this product. So it is not a biological product. So most often it is small molecule, low molecular weight, and so chemistry is not very complex, but the biological product of human cells are most often complicated with high molecular weight. So the chemistry of biosimilar is complex. The chemistry of small molecule no matter how much it is precise, but it is simple comparing to biosimilar. So small molecular generic is the low molecular weight. Chemical synthesis only. The biosimilar is by living organism. The manufacturing process is easy by the reverse engineer. But in biosimilar, we cannot reverse the living process of producing the substance. We have to know the detail of the process by the manufacturing of the originator. And generally, the small molecule generic is possible to exactly the same molecule because it is physics and chemistry. But in biosimilar, it's possible to reproduce the molecule with a high, very high, whatever you want, but we cannot be sure it is 100 similar to the originator, but we must be very close to 100 of biological activity. But because biology is very variable between cells and cells, between process and process, we must be very very precise about the how to prove that our biosimilar is highly similar to the originator. So it is a cartoon to say you small molecule, we can produce exactly the same as generic, but when we have a biological medicine, if we are not very very scientific, very regular, you will see very different molecule on the right. So the process of producing the biological medicine of the originator doit être très précise, very precise. So another way to show you, another slide to show you the difference between biosimilar and reference biologicals, I had to stress that the same process of manufacturing and the clinical development and regulation is almost the same, but only we don't need to prove the efficacy of our biosimilar always in the same way of the originator, unless sometimes we have to do it. But so if we go from top to the bottom, we have the same biological process, the same sensitivity to process changes, and it is reproducible the same way. Clinical development, we have extensive phase 1 and phase 3 for our clinician. We know that our biosimilar has received an extensive clinical study of phase 1 and phase 3, and the pharmacovigilance is the same rules as with the reference biological. The only difference is when you have to do as the first principal point of demonstration, we have to demonstrate that we have a similarity to a reference product, not identity. It is a comparable, and the regularity pathway by EMA are the same for the two, the biological originator and the biosimilar. So development of biosimilar requires many of the same stage as development of biologics, with a little gain of 2 or 3 years between the two process. To establish biosimilarity, the sponsor must first show that the quantity is highly similar to the reference product at the analytical level. This can take multiple iterations in early stage development before clinical testing may begin. The sponsor must also perform detailed analysis of the reference product, especially if the structure and biological function is inadequately defined. So, biosimilar, we have a similar structure, similar PK, pharmacokinetics, and pharmacodynamic to the originator, similar in clinical efficacy and safety, same presentation, dose, strength, administration mode, and similar in immunogenicity. Immunogenicity is not requested for generics, for the small molecules, but it is requested for the biosimilars. So development approach closer to gens and generic, yes, development approach, we have to develop a generic, we need 2 to 3 millions, but to develop biosimilars is 100 to 150, comparing to 800. So we have gained here 700 millions in the development investment by the pharma line of the product. So biosimilar is still, it is costing 100 million to 150, comparing to 800. but a small molecule generic 2 to 3 millions only. Time to market, you see that biosimilar can be saving 1 or 2 years for the access to the market, and the study can be smaller little bit than the study. The phase 2 and 3 are requiring less number of patients, 500 comparing to 1,000 for reference product. Why a copy biology is not a biosimilar? Because if you don't follow exactly, you see here that we have a biologic copy, not a biosimilar. If you don't have exactly what is the process of the synthesis of the originator, you cannot reproduce only a true identical biological product. It will be a copy, which you see that by chromatography here, that we don't have the same profile between the originator and the copies. So we wait for the patency. We wait for the patency and we go for the synthesis of biosimilar. So non-comparable copy biology is different of biosimilar, not similar to reference product. You have here the gel electrophoresis of 11 erythropoietin not approved in the EU. We have to go by the rules. If we follow the rules of European Union and of the A, we are sure that our biosimilar is highly similar to the originator. And here, if you go for what is approved in Europe for the biosimilar, you see that there is no difference to originator reference. So you have here 1 and 3, you have the 2 biosimilar, and you have 2 and 4 reference product. So gel A and gel B, you have the identity. So I think bottom of the line, we are in the middle of my conference. I have to wait also for some other slide to tell you the bottom of the line. If it is approved by Europe and by United States, we go with no doubt that our biosimilar is as effective, as tolerable, as safe as the originator. And because it is less costly, the biosimilar, and especially in our condition now in Lebanon and all over the region, also we can have a more affordable drug. And if we have here a small exercise of economy on the left, if you go by a 40% price reduction in the States, they economize 106 billion milliard. It's different maybe for our countries, but 40% of price reduction in biological products is very important. It's because in the States we know that the money spent on biological products is gaining around 20 and 30 and 40% of the expense of new drugs in the States. So any percent of reduction of the price of the biological products by a biosimilars will be in absolute number a very great decrease in the expense on the health. Biosimilar provide the opportunity to prescribe high quality, cost-effective medicine to patients who could benefit from biological therapy. And I think it is time to say, maybe we have Sandoz, which is a big pharma for biosimilars, and maybe if we have many other so important companies that like Sandoz, Novartis division, which is a Novartis division, if other big pharma in the world go also for the biosimilars, I think that is very important to make biological products more affordable, because the price become more and more extensive, especially for the new monoclonal antibody used, the newest than the rituximab in non-Hodgkin lymphoma, in multiple myeloma, in acute leukemia. And I think it is the time to push for biosimilars after the end of the patency of our originator, of course. But we have some drugs, we can, some monoclonal antibody, we can go and hope that we will have soon biosimilar for them. So the Rixathon in non-Hodgkin lymphoma, I will go here very rapidly, was studied in the, I'm sorry, we go for the Rixathon. The oncology is facing unsustainable crisis of affordability, rising cancer incidence, rising cancer lymphoma incidence, and the survival of the become very important, prolonged by many new drugs. So we have to invest in, of course, like all cancers, in prevention, but also we have to invest in effective treatment and non-toxic treatment. The development of biosimilar is, as already mentioned at the start, beginning of the conference, by very few steps of analytical, chemical, preclinical, animal, and ex vivo, pharmacokinetics and thermodynamic study, and clinical confirmation, and post-marketing study. Like all, the Rixathon has followed the same process of any respectable, if I may say, biosimilar, and it is like the originator has follow the steps of process like must be. And once established biosimilarity is confirmed by clinical study, and it was done for the Rixathon, and the totality of evidence principle provides scientific justification of the extrapolation of the biosimilar to the indication of the originator. Still, the Rixathon did a study on clinical ground, phase 3 study, comparing the Rixathon with placebo and assist for follicular lymphoma. The study was published in Lancet Hematology in 2017, comparing 300 patients with Rixathon CVP and placebo CVP, with the reference, I'm sorry, with the rituximab CVP. And so we compare Rixathon to rituximab, the originator rituximab, the MabThera, and we have the same response, objective response, and we have the same efficacy and the same toxicity, no difference between. The incidence and severity were the comparable between treatment group, and the immunogenicity and the reaction à l'infusion was the same. So, and if you go for the pharmacodynamic PD on the right, you have the same PD graph for the two, for the originator, the rituximab originator, and the Rixathon. So in the real world evidence, it was another study, the Oncology study, and it was published. In the Future Oncology, and later also presented as poster in the EHA virtual EHA 2020 Congress. And it is a work of 70 physicians, 23 centers, and 1,741 patients. Of these patients, we had 29% CLL, 18% follicular lymphoma, 14 patients diffuse large B-cell lymphoma, and other non-Hodgkin lymphoma. As you see, we don't need to go and do a phase 3 study in all this indication. We extrapolate the indication from the originator, especially that the identity and similarity of the Rixathon was proven in one single indication, which is the follicular lymphoma. You see that, as you see there, that we have a very highly more and more in this study in real world has shifted to the use of biosimilar to rituximab with time. And biosimilar usage was 83% after 2 years of this of the following of the Oncology study. So the first real-world post-approval data of rituximab biosimilar in diffuse large B-cell lymphoma was presented in the, as poster in the virtual EHA 2020. And you see there that you have the same treatment-related adverse event and non-treatment related events. It is very comparable, the percentage to the originator. The overall response rate are all also very comparable to the efficacy, to our knowledge about the efficacy of rituximab originator in diffuse large B-cell lymphoma. And so entering baseline data and these characteristics were as expected for treatment naive patient. I'm sorry, with CD20, sorry. Potential to provide saving for a healthcare system, of course, broadening patient access and support the sustainability of cancer care. the product pile, you have a difference on favor of Rixatan that we can store a longer day when we have an infusion bag, but we have the same rules or almost. I'm sorry. Rixaton, the long-term commitment to cancer care from Sandoz. Of course, Sandoz is a branch of Novartis, and Novartis also a big pharma in the oncological line and in the hematological line. Rixaton matches the reference rituximab with proven efficacy and helps supporting health cell system, and especially Lebanon.
Thank you, Dr. Nabil Shamsuddin, for this very nice and complete presentation. I prefer to take the question at the end of the presentation after the presentation of Professor Ahmed Ibrahim. Dr. Ahmed Ibrahim is professor and head division of hematology oncology at Maqasid General Hospital, also director of BMT program at Maqasid and Middle East Hospital, president of, actual president of the Lebanese Society of Hematology and Transfusion. Dr. Ahmed has a long experience in the treatment of lymphoma. So we will make the presentation, Ahmed, for Dlbcl lymphoma review in the treatment.
You can control.
We don't hear you.
But you
hear
can
me?
start. Probably connection problem. You may start, please.
We stop.
Yes, Dr. Ahmed, you can give the 2 lectures.
Yes. Can start ولا I wait for?
No, you can start.
عم تسمعوني لكن. Okay. So good evening. Thank you for the kind introduction, Professor Sheikh. I would like to thank the organizer and Sciences Po for this educational meeting. My talk is about 30 minutes, will be about 30 minutes. It will be on the treatment approaches to this diffuse large B-cell lymphoma, if we can go better than R-CHOP, and an update of the studies first-line therapy for this disease. So I have to move. So diffuse large B-cell lymphoma is the most common non-Hodgkin lymphoma, in about 30% of lymphomas. It is a disease of elderly in more than 50% of the patient, more than 60 years old, and 1/3 of the patient are in advanced disease with IPI 3 to 5. The clinical features are heterogeneous from nodal to extranodal, etc. And we have to take into account that for elderly patient, particularly unfit and frail, we have to be careful in the therapy of the disease. 60 to 70% of the patients are cured with frontline therapy. And most patients are treated with R-CHOP, 6 to 8 cycles. And if the disease is refractory, to second-line therapy has to be done, and the prognosis is poor, and the transplant is here. So I have a problem in progress. Okay. So R-CHOP in first-line therapy still has been the standard of care in this disease. And you have here the GILA now, the LISA. The results update the 10 years follow-up for R-CHOP in terms of survival. And you have R-CHOP doing better than CHOP significantly for this patient in terms of PFS and overall survival. However, we cannot exceed more than 40% at more than 10 years. Next slide, probably, yes. which is important the last 20 years, that the gene expression profiling in DLBCL appeared interesting in the categorization of the disease, the prognosis, and the therapy. And the last 20 years appeared that two types of diffuse large B-cell lymphoma are here, with the GCB-like and activated B-like. And GCB-like does better than ABC-like, ABC-like lymphoma, significantly better. I told you. Next slide, please. Here you have on this slide the distinction between the two types, the CCB-like and activated B-cell-like. You have BCL2 translocation 1418 and CC amplification in GCB. However, at +3, 18q21 and BCL6 are present in activated B-cell-like. And in terms of other pathways, NF-kappa-B, FOXP1, MUM1, IRF4 are implicated in ABC-like. However, BCL6, CD10, MIB-L1, NEC6, and LMO2 are implicated in GCB and BCL2 in between. And you see on the right the discordance in terms of DNA in immunochemistry studies. Next one, please. And in this recent communication, in translation medicine communication, you see that the GCB has a better prognosis than ABC, significantly better, because at more than 5 years, 85% with the GCB did well, are survivors. However, only 60-65% with ABC. Next slide, please. And this is in liquid and tissue biopsy, so better than immunohistochemistry. Next slide, please. More and beyond GCB and ABC, the expression of MYC, BCL2, or BCL6 appeared interesting also in differentiating better or worse diffuse large B-cell lymphoma groups according to the expression of MYC, BCL2, or BCL6. We have double expressor with increased expression of MYC and BCL2 by immunohistochemistry, and double triple hit with the presence of translocation involving MYC, BCL2 and or BCL6. And the incidence of expressor is 30% to 35%. However, the triple double hit doesn't exceed 10%. In these aggressive lymphomas, we have extranodal involvement, refractoriness to standard chemotherapy. So a lot of work has been done in this type of disease. And the expressor and triple hit, double hit have a less favorable prognosis with R-CHOP, only 2 years median overall survival maximum. Next slide, please. To be more complicated, in the GCB and non-GCB, we have double expressor and also triple hit or double hit. And sometimes we have unclassifiable non-GCB diffuse large B-cell lymphoma. In this case, sometimes treatment is not clarified, is not efficient, and more biological and molecular work have to be done in this field. Next slide, please. A lot of work has been done to improve the result of R-CHOP, particularly in these aggressive types of non-Hodgkin lymphoma, as I showed you. The first thing was to intensify CHOP. Instead of doing R-CHOP every 3 weeks, do it every 2 weeks. And here you have the reports 10 years ago with no difference in terms of PFS and overall survival. One R-CHOP 14 was compared to R-CHOP 21. Next slide, please. R-ACVBP promoted by Lisa with a super CHOP every 2 weeks was compared to R-CHOP every 3 weeks. And it appeared that in patients younger than 60 with a good AIPI, these patients did well, significantly better with R-ACVBP with survival exceeding 90% at more than six years compared to R-CHOP. So it appeared that R-ACVBP was adequate for younger patients with a good IPI compared to R-CHOP. Next slide, please. The Alliance CLGB 5333 compared R-CHOP to more aggressive therapy, different a little bit than R-ACVBP, R-EPOC in newly diagnosed Dlbcl, and with a primary endpoint EFS for untreated patients with newly diagnosed Dlbcl. And in this study, almost 475 patients were included. Next slide, please. However, no difference was obtained in terms of event-free survival and overall survival when those adjusted EPOC R was compared to R-CHOP. Next slide, please. However, GCB benefit better from those adjusted EPOC, as you see on the left, was almost 90% event-free survival of long term compared to non-GCB. So with GCB with R-CHOP, and particularly with more intensive chemotherapy than R-CHOP, the results are here good. The problem is one with non-GCB, particularly in particular ABC-like type. And effort, logically, has been done the last 10, 15 years for non-GCB compared to GCB. Next slide, please. When we see R-CHOP in double hit or triple hit, R-CHOP was not so efficient. And you see here that in the blue curve, you have almost 20% long-term survival. However, EPOC have received more intensive therapy, as I showed you previously with the EPOC. EPOC was more efficient compared to R-CHOP in double hit and triple hit. So in this aggressive therapy, probably intensifying chemotherapy with R is better than using CHOP with R, basically. Next slide, please. The last 15, 20 years, major signaling pathways were targeted after the understanding of and discovering of these pathways, particularly B-cell receptor, BCR, with the BTK the pathways, or tool-like receptor with at the end NF-kappa-B pathway and IRF4. The understanding of these pathways raised and many studies been done using target therapy after understanding these pathways, and the major signaling pathways were targeted in combination with R-CHOP to see if these target therapy combined with R-CHOP did better than R-CHOP alone. Next slide, please. The first one, bortezomib, as I show you, in F-kappa-B is implicated. So bortezomib, many studies were done, and I would like to show you the most important one, the LB, the phase 3 comparing R-CHOP to B-R-CHOP, bortezomib R-CHOP. Next slide, please. In this study, no difference were obtained in terms of overall survival or PFS in the whole population, comparing BR to R-CHOP. But next slide, please. When we go in more subgroup analysis, we see that B-R-CHOP was interesting in double heater and double expressor than in non-double heater, non-double expressor. And probably this could be a kind of therapy to be used in double heater or double expressor. Next slide, please. Next slide. Now coming to IRF4, lenalidomide was added to R-CHOP and compared to R-CHOP alone. And here is the most interesting study of these four published previously. The robust one is a multi-center one, 560 patients, compared R-CHOP to R2-CHOP. Next slide, please. Almost 570 patients with 208 patients in each arm. Next slide, please. And you see no difference in terms of PFS or overall survival R2-CHOP with R2-CHOP compared to R-CHOP. However, when the subgroup analysis, next slide, please, see that, next slide, please, that patient with IPI, no, the previous one, patient with the previous one, please. The previous one, okay. So with IPI, the previous one, because in the previous one we see that one IPI is, yes, with IPI more than, more or equal to 3, with this, in this subgroup, R2-CHOP did better than R-CHOP. Probably, if we want to use lenalidomide, probably it's better to use it when we have a very advanced and bad IPI index, in high IPI index in diffuse large B-cell lymphoma. Next slide, please. The third molecule is the ibrutinib. I show you that BTK was implicated in the pathways, and this is the randomized study, phase 3 trial, ibrutinib R-CHOP versus R-CHOP. We have in this study almost 838 patients were included, and in each arm almost 420 patients were analyzed. And next slide, please. You see, no difference is obtained in terms of EFS or overall survival between R-CHOP and ibrutinib R-CHOP. However, when we go in the subgroup analysis, we see that, next slide, please, the patients younger than 60 years old, did better than elderly patient and older patient in terms of particularly EFS and then OS, but clearly in EFS. So ibrutinib interesting in advanced disease with age less than 60. Next slide, please. And when we see in non-GCB, co-expressing BCL2 and MYC, when we have this expression, it's interesting to use this combination because it brought the prognosis and the survival to GCB type. So 20% at least higher in terms of event-free survival. So, and overall survival. So probably interesting in a double expressor or double heater. Next slide, please. Now coming to BCL2, and here on this slide, you have the importance of BCL2 as a pathway in the Dlbcl. Next slide, please. So anti-BCL2, particularly venetoclax, was investigated. And this is a phase 2 study of venetoclax plus R-CHOP compared to R-CHOP. In this slide, you have the Cavalli study, this one, the phase 2 with the venetoclax R-CHOP, and you have the Goya. I will come to the Goya later, using comparing Gazyva to Maptera. And in the Cavalli, so a head-to-head was done comparing patients with venetoclax R-CHOP with MAPTERA R-CHOP or MAPTERA CHOP or Gazyva CHOP. And you see that when the BCL2 was expressed in fish, you have better response, PET-CR rate higher, 70% compared to 48%. And interesting in double expressor and particularly double heater with 71% with venetoclax compared to 25% with anti-CD20 plus CHOP, as you see in the bottom of the slide. Next slide, please. So interesting in terms of CR and also interesting in terms of survival with the PFS and OFS significantly higher with BCL2 with the BCL2 expression and double expressor. So interesting, venetoclax interesting when you have a double heater, triple heater, or double expressor where BCL2 is incriminated and well expressed in immunohistochemistry. Next slide, please. And here you see the curves, what I showed you in tables, curves with significant difference in double heater and in double expressor. Next slide, please. See in this slide, better you have the PFS in the overall population on the left, and you see the clear difference when BCL2 is expressed by using venetoclax. You have PFS in blue on the right, in blue curve in the Cavalli, compared to non-venetoclax usage for these patients. Next slide, please. Next slide, please. However, the problem of venetoclax with R-CHOP is a toxicity with 20% of the patient discontinuing therapy and 55% reducing therapy when you add venetoclax to R-CHOP. So we have to be careful in terms of toxicity, and sometimes we have death, 16% in the Cavalli study when we use venetoclax with R-CHOP. Next slide, please. Now coming to monoclonal antibodies. You see on the slide the number of antigen and novel antigen discovered in diffuse large B-cell lymphoma, and this allowed the studies using antibodies against this antigen with a novel agent as therapeutic strategy, a new therapeutic strategy in Dlbcl. Next slide, please. And in this slide, see that these discoveries, these antibodies could be monoclonal antibodies or radioimmunotherapy antibodies or antibody drug conjugates or CAR-T or bispecific T-cell engagers or immune checkpoints inhibitors and others. Next slide, please. And the first study compared Gazyva, super MAPTERA to MAPTERA, super anti-CD20 to anti-CD20 in newly diagnosed patient. Obinutuzumab at 1 gram plus CHOP 6 to 8 cycles was compared to rituximab CHOP 6 to 8 cycles, as you see the design here. And next slide, but no difference obtained in terms of survival between R-CHOP and Gazyva CHOP in first-line therapy in diffuse large B-cell lymphoma, as you see on the studies presented a few years ago. Next slide, please. A new antibody, anti-CD79B, investigated in relapse in diffuse large B-cell lymphoma, was investigated in first line. Polatuzumab vedotin here in phase 1B and 2 trial was added to R-CHOP and or Gazyva CHOP in patient with advanced disease. And here you see that CR rate was 77% with PFS exceeding 90%. Very good results with this monoclonal antibody added to R-CHOP or J-CHOP. And EFS 80%, with no difference in PFS observed with different number of treatment cycles, 6 versus 8, or anti-CD20 therapy R versus J, or IPI, advanced versus non-advanced. The PFS was similar in different molecular subtypes, which is important in double expressor, double heater, or GCB or non-GCB. And now there is an ongoing study, Polarix, comparing, this is a phase 3 study comparing polatuzumab plus R-CHP versus R-CHOP in patients with untreated Dlbcl. In the coming year, we will have the first intermediate results of the study involving 875 patients in 24 countries. Next slide, please. CD47 and anti-CD37 recently has been investigated in diffuse large B-cell lymphoma, with the importance of the expression of CD47 to define efficacy of R-CHOP in non-GCB patients. Here you have that in these studies, CD47 expression defined clearly the efficacy in non-GCB. When you have low expression in non-GCB, the results of R-CHOP is better, and probably anti-CD47 will do the job compared to a higher expression. So it's better with non-GCB to have lower expression of CD47 to have the efficacy, better efficacy of R-CHOP. However, in GCB, there is no clear difference. So lower CD47 expression is better than a higher CD47 expression for R-CHOP in non-GCB. Next slide, please. That I gave you the results of that, the conclusion of the 2 slides. And next slide, please. Beyond monoclonal antibodies, we have now bispecific antibodies, and recently at the ASH, a very interesting report with single agent mosunetuzumab with promising results and safety in patients with the newly diagnosed diffuse large B-cell. Next slide, please. This drug, next slide, please. This drug, which is a bispecific anti-CD3, anti-CD20 bispecific antibodies, was investigated in elderly patients. Normal to start with elderly patient, not tolerating chemotherapy, not tolerating CHOP, and necessitating therapy. So more than 75 years old with advanced disease. And next slide, please. You see here, next slide, please. Next slide, please. And here you see that in the study design with the pre-phase treatment with different doses and step-up dosing of this specific antibody during the cycles, during the cycle 1, day 1, 8, and 15. The first safety cohort dose, here you have 1 milligram at day 1, C1, day 8, C1, 2 milligram, then at C2, 13.5 milligram. The second safety cohort, 30 milligram. A third safety cohort, also 30 milligram with different dosage at C1. Next slide, please. The 29 patients were included in the study with a median age of 82 years old, with 50% of the patient with a high IPI score and bad performance status in more than in 30%, with extended disease and extended stage in more than 50-60%, and non-GCB in more than 50%, with double heater, triple heater in almost 20%. 29% enrolled. Next slide, please. And here you see that the safety profile was acceptable with a few very a high adverse events score. The majority of the patient develop mild side effect, rash, particularly cytokine release syndrome, fatigue, some neurological syndrome, and some muscle pain, or we have neutropenia also in a few patients. Next slide, please. And here you have the CRS event, mostly grade 1, so limited in this bispecific antibody. Next slide. And also neurological symptoms were not very high. The efficacy, interesting, the 30 milligram, 50% of complete remission and 7% of partial remission in this advanced disease in elderly not tolerating chemotherapy. Next slide, please. So the median follow-up of almost 5 months, the median duration of response was not reached. And of the 10 patients who progressed, 9 received salvage therapy and are alive. And all of the 4 patients with double hit or triple hit, 2 CR were obtained. So very interesting results, but very early to conclude. We have to see in the coming years what will be the results in higher number of patients and different subgroups. Next slide, please. Next slide, please. Another study is the ZUMA-12 study, this CAR-T in patient with high-risk Dlbcl who received after 2 cycles of systemic therapy in very high-risk patients, received CAR-T after conditioning chemotherapy, and the CAR was axi-cell in this case, and conditioning with fludarabine and cyclophosphamide. In single IV infusion, 10 to 6 CAR T cells were infused at day 0 with a primary endpoint CR. Next, so first induction therapy followed by consolidation therapy with CAR T, which is very interesting and very new in such high risk patient in order to improve survival and DFS. Next slide, please. Here, 32 patients were included, median age 61, with the 88% advanced stage, with the double hit or triple hit in 50%, IPI score high in 72%. Next slide, please. So very aggressive disease. Here the overall response, 85%, impressive. 74% CR, 11% PR, with a median follow-up of 9 months, and the patient had with ongoing response at data 70% ongoing response at data cutoff, and the median time to response was quick, 1 month. And with CAR-T improved response from PR to CR in 4 patients of 15, and stable disease to CR in 1 patient over 4. So very interesting. Next slide, please. And here you have continuous complete response or partial responses in high number of high percentage of patients. Next slide, please. The neurological events were not very aggressive. Grade 4 in 2 patients, and encephalopathy resolved with no grade 5 in any patients. Next slide, please. The CRS, also no grade 4 or 5 CRS in this CAR-T program. Next slide, please. Oh, after immunotherapy, a question is still here. Is autologous stem cell transplant as consolidation in responder patient interesting or not? Lisa investigated this several years ago in advanced and high risk score. It was not used in the United States of America. And here we see that EFS could be interesting in such a patient consolidated autologous stem cell transplant. 71% EFS versus 60, but no difference in overall survival. For some patients, we continue to give autologous transplant as consolidation in the diffuse large B-cell lymphoma, but it is not widely used. It is used in some selected patients. Next slide, please. The maintenance therapy after R-CHOP, beyond R-CHOP, is it interesting or no? The majority of the studies reported lenalidomide as maintenance therapy. Some studies R2 is maintenance therapy after R-CHOP. In strict sense of diffuse large B-cell lymphoma, some studies reported significant DFS or PFS. However, this is not widely used, and it is not in the guidelines as maintenance therapy for diffuse large B-cell lymphoma, which is the case is different in another type of aggressive lymphoma. And the majority of the groups don't use lenalidomide as maintenance therapy or R2 as maintenance therapy after R-CHOP if the patient is responder or NCR. Next slide, please. Is radiotherapy still interesting with R-CHOP or other combination, more aggressive combination, or new target therapy? With new target therapy, we don't know because we don't have a lot of studies adding radiotherapy and comparing it in the randomized study to non-radiotherapy in targeted therapy, but in the era of targeted therapy. However, in a classical era with R-CHOP or sometimes more aggressive CHOP, bulky patient with bulky disease benefits from radiotherapy as consolidation compared to non-bulky disease, compared to R-CHOP without radiotherapy. So sometimes it's interesting to add radiotherapy in patients with bulky disease after R-CHOP. Next slide, please. This is the in 2021. What is the profile of survival of diffuse large B-cell lymphoma? Almost 60%. And you have the time to progression, progression-free, and overall survival with a classical treatment. And early usage of, and recent usage of target therapy. It was reported in the New England Journal of Medicine by Sen and Gilles Sal a few 2-3 months ago. Next slide, please. Next slide, please. And we have to pay attention with the new target therapy, new era of therapy to some groups of patients still with bad prognosis. ABC non-GCB, double triple heater, double expressor, higher proliferative disease, P53, deletion of CDKN24 locus, loss of expression of major histocompatibility class 2 types, low lymphocyte count of, and low lymphomonocyte ratio in diffuse large B-cell lymphoma presentation, and a host genetic with single nucleotide variation in 5q23 or 6q21. All these groups are associated to bad prognosis. And in all these groups, a lot of effort is done currently with the new targeted therapy. So it's important beyond R-CHOP. This group needs more than R-CHOP, and you have to go beyond R-CHOP in these groups. Next slide, please. Beyond R-CHOP, after the next slide, please. Beyond R-CHOP, we can more investigate CAR-T, monoclonal antibodies, antibodies that are conjugated, conjugates by specific antibodies, NF-kappa-B modifier, other agent anti-BCL2, like anti-BCL2, checkpoint inhibitor, epigenetic modifiers. And the results, phase 1-2 studies start to appear with promising results with some classes or groups of therapy, like CAR-T, like tafasitamab, like bispecific antibodies. You see that we can exceed now in a very, very bad and tough disease groups, 60-70% overall response rate and complete response rate. So a lot of studies are ongoing investigating these new drugs beyond R-sharp in these groups of bad prognostic DLBCL. Next slide. So we are moving beyond R-CHOP by targeting molecular classification subgroup. And in the recent, in this presentation, in this article, in this recent paper published in New England by Sen and Dlbcl, as I told you 2 or 3 months ago. So we have the GCB-like or ABC-like with the immunoglobulin somatic hypermutation in each group, or particular genetic lesions like 14, 18, BCL2, 10, etc. for GCB, or CARD11, CD78, TNF, FP, and FKB in activated B cell like. Particularly, we are now to 5 DLBCL clusters. Probably we will have more and more clusters in the future, but currently we are discussing 5 DLBCL cluster with particular genetic hallmarks for every cluster, and biological pathways deregulated known now in every cluster. For example, B cell receptor and NF-κB signaling in cluster 5, MCD of activated B cells. And in each GCB and ABC, we are now identifying more favorable, less favorable group, and a targeting therapy according to biological pathway, genetic hallmarks, and clusters. And this is the present and the near future. And we see in the future studies in analyzing the clusters and the therapy, adequate therapy to these clusters. Next slide, please. And I will finish by this algorithm, this guideline for diffuse large B-cell lymphoma, also presented by Sen and Dlbcl. Look in the middle, diffuse large B-cell lymphoma staging, biological PET scan, etc. And we have a limited stage where 3 cycles of R-CHOP and radiotherapy could be done, or 4 or 6 cycles plus radiotherapy could be done in the bulky disease, and PET guided after 4 to 6 cycles to decide further therapy. And the advanced stage, 6 cycles of R-CHOP to 8 cycles are still here, but new agents have to be considered in high risk subgroups. We could have primary refractory, complete responder, or in the primary refractory, which is represent 10% maximum limited stage, but 25% in advanced stage, we have to treat a relapse, and relapse could be platinum-based salvage therapy or new target therapy, new immunotherapy associated to chemotherapy, and we can go to autologous transplant in responder patient. However, in refractory patients, we have to investigate more newer lines of therapy, particularly immunotherapy, CAR-T, antibodies, selinexor, bispecific antibodies, and sometimes go to allogeneic stem cell transplantation. And I would like to thank you for your attention.
Thank you, dear Ahmad, for this very nice and complete presentation indeed. For the first time, Dr. Ibrahim completed this general overview in the DLBCL treatment and the best timing. Thank you, Ahmad, for this presentation. I want to say sorry about the interruption before due to the electricity, and we can move now with the presentation of Dr. Khalid Ibrahim, Clinical Associate Professor of Hematology Oncology at Beirut Arab University, Lebanon. Khalid will talk today about redefining treatment in frontline multiple myeloma patients. And we will make the question at the end of this session. I want to say also that I don't have any conflict of interest to declare due to this presentation, all the presentation. I don't have any conflict of interest of any of this presentation. Thank you. Khalid, the floor is yours.
Okay, good evening. I will start by thanking Dr. Farhat and Dr. Khatib, as well as Jensen for being here, for having me to present the data on the newly diagnosed transplant-eligible patient with multiple myeloma, the data of Cassiopea, which is the daratumumab VTD versus VTD. To begin with, let's start by giving the Janssen a salute for the commitment to improving outcomes in multiple myeloma. You know, you all know the famous data of bortezomib in 2000 and the incorporation of bortezomib in the life of multiple myeloma, the treatment of multiple myeloma had and still having a great impact in terms of progression-free survival and survival for patients with multiple myeloma, whether we're talking about VTD or VRD or VBMCP, you know, a lot of regimen. We will have to have the time to review the history, but nevertheless, incorporating bortezomib in the treatment of multiple myeloma had, as I told you, had and still having a great impact for outcome. Next slide, please. The issue that we all know as hematologists and oncologists, that multiple myeloma gets harder to treat with each relapse. And unfortunately, despite all the advances that we have in multiple myeloma care, the disease remains uncurable and almost all patients relapse after treatment. And now if you look at the curves, it's very representative of the usual course and timeline of patients with multiple myeloma. And the problem is, as much as time is elapsing, patients grab more and more comorbidities, and many of these patients do not reach their next line to therapies, which means what? Next slide. This means that the benefits of early intervention, as I'm using in a common way to talk, if we hit hard from the beginning, probably we will ensure a better outcome for patients with multiple myeloma. And this means also that efficacious and early efficacious intervention encourages complete remission. This is the aim that we're targeting whenever we are treating our patient. So therapy that induced remission is more likely in patients with newly diagnosed multiple myeloma than in the relapsed refractory setting. Next slide. I will start by just illustrate a regular case that we all see in our clinics. It's about a 48-year-old patient, previously healthy woman that started noticing acute onset and gradually worsening neck pain approximately 4 months before her presentation. Now, 2 months ago, she noted that the pain increased in severity and started having a burning sensation. She denied any fever, chills, night sweats, or weight loss. Now, MRI of neck revealed a C3 pathologic fracture with a left chest wall mass. CT neck, chest, spine, and MRI of spine revealed numerous enhancing lesions in cervical, thoracic, lumbar, vertebral spine, as well as a mass in the left first rib. What was the workup? Next slide, please. A CT-guided biopsy of the left first rib lesion showed plasma cell neoplasm. Now, additional lab testing suggests, lab testing, creatinine with a 0.8, calcium normal, albumin 4, hemoglobin, she was normocytic anemic, the beta-2 microglobulin was 2.7, the total protein was 9.9, with an IgA-M paraprotein and free kappa light chain of 104.7, as well as an FLC ratio of 16. The patient was considered to be an RISS stage 1, and the bone marrow biopsy revealed 50% plasma cells with fish, which is a very important point. I'm not gonna have time to discuss, but this is an important point whenever we are contemplating to treat a symptomatic patient with multiple myeloma, to have all this panel. Fish was negative for 11, 14, deletion 17, TP53, deletion 13q, and monosomy 13. The fish, on the other hand, the fish was positive for gain of 1 copy of 11q, consistent with trisomy 11, trisomy 3, trisomy 7, and trisomy 9. Next slide, please. Well, we should treat probably. She's a symptomatic patient that need treatment. How would you treat? To begin with, she's transplant eligible. We don't have comorbidities that preclude the transplantation. The options that we have in 2021, and I'm talking here about options outside the clinical trials, the approved options, VRD, autologous stem cell transplant. I'm not going to continue with the consolidation and maintenance, whether it's VRT or VTD or VCD, KRD with the high dose treatment. I'm talking about 4 options using triplets. Now you know that we are in the era of using quadruplets, especially after the incorporation of daratumumab in the practice. Now, the 2 other options, DARA VTD, followed by autologous stem cell transplantation, consolidation, and maintenance, or DARA VRD, autologous stem cell transplant, consolidation, and maintenance. Next slide, please. This patient has a standard risk symptomatic myeloma, and she was treated with DARA VTD for 4 cycles, followed by high dose treatment and stem cell transplant, followed by DARA maintenance. Next slide. Why we considered this? Well, we have evidence. We have evidence, and recently, you know, the trial the Cassiopeia trial was presented as the part 1, as you will see. And recently at ASCO, the part 2 was also presented. Let's go a little bit to the Darzalex. No, please. Yes. To Darzalex. What is this drug? Well, Darzalex is an anti-CD38, a monoclonal antibody. It promotes myeloma cell death through both direct anti-tumor activity and a systemic immunomodulatory role, namely through CDC, complement-dependent cytotoxicity, antibody-dependent cell toxicity, also through antibody-dependent phagocytosis and apoptosis. On the other hand, this drug is very smart because it ends up attacking the CD38 and to have the immunomodulatory action. So it has a dual action. Next slide, please. And because of the data that I'm gonna discuss briefly, the new ESMO 2021 clinical practice guidelines recommended for multiple myeloma front treatment as 1A, the combination of daratumumab with VTD. And I will urge you to read this paper. It's a very nice paper. I think it's mentored by Dimopoulos, already published online. It's a kind of review of all the recommendation for the diagnosis and treatment of even smoldering myeloma and reaching multiple myeloma. Next slide, please. Cassiopeia constellation. There is a constellation, and if you notice that many of the studies of Janssen in multiple myeloma are named by star names. Now, what is this? What is this trial? A very elegant trial. It's a phase 3 trial. Dara plus VTD versus VTD standard of care in induction in newly diagnosed patient multiple myeloma transplant eligible. What they did around 600, around 1,000, more than 1,000 patients, and they randomized them 1-to-1. Arm A VTD for 4 cycles, Arm B VTD plus Dara for 4 cycles as induction. After 4 cycles, the patients were underwent stem cell mobilization, conditioning, and transplant. On the same time, another part of the study looked at next generation flow, next generation sequencing, and PET. After that, subjects with partial response or better, they continued VTD for 3 cycles or VTD plus Dara for 3 cycles, which is the consolidation phase. And then after that, a second randomization, which is the phase, the part 2 of the study, observation versus Dara to 8 weeks until progressive disease, maximum of 2 years, followed by observation, which is the maintenance phase, and then the follow-up. Now, the primary endpoint was the stringent complete remission by the response criteria, and the secondary endpoint was complete remission, MRD, and progression-free survival. Next slide, please. Now, all patients were demographically and characteristically were equal, the same, Of note that around 70% of them were 70 to 80% were stage 1 and 2, so 38 and 47. And also very important thing, 85% were standard risk versus 15% in both arms. Very well balanced in demographically and in this also by the risk percentage. Next slide, please. Now, what is interesting here? In the intent of to treat population, and looking at the response rate in red, the response rate over time, 60% increase in favor, in stringent complete remission in favor of the combination or quadruplets. 53.8% of patients achieve more or equal complete remission versus 38.5% in favor of VTD, which is around double or 1.5. So looking at this slide, what we can tell that the primary endpoint in favor of favoring the quadruplet in terms of stringent complete remission was achieved. Next slide, please. Now, when it comes to progression-free survival, it's looking at the 18-month PFS, it's in favor of the quadruplet, with a 53% reduction in risk of disease progression or death. This is also in the intent to treat population. Next slide, please. When it comes to a very important issue, which is the MRD negativity, 69% was in favor of the combination. Next slide, please. This is just one slide to summarize all the things that I was telling you. We can jump to the next slide, please. Now, if you look at the pre-specified subgroup, the durable PFS was consistent in all groups, including ISS3 and high-risk cytogenetics. Next slide. Next slide. What about safety? No safety compromises. The combination of dara with VDD had a manageable safety profile with no notable increase in overall toxicity. Next slide, please. Now, the most common treatment emergent adverse events were similar and had similar rates in both treatment arms, which is 47% for adding daratumumab to VTD versus 47% in VTD. And the toxicity was very low, and a grade 3 or 4 toxicity was very low. The majority were grade 1 and 2, also all manageable. Next slide, please. Now, the rate of infusion-related reactions was consistent with other phase 3 trials of Darzalex. So adding VTD to Darzalex didn't increase this toxicity. And all the toxicity also were grade 1 to 2. Next slide, please. What about infection? Well, infections were manageable. Only 1% of patients on DVTD discontinued treatment. Rates of more than grade 3 pneumonia were 4% in the DVTD group and 2% in the VTD, comparable no signal of increased infection and toxicity in the combination group. Next slide, please. This is a slide just to remind you about pre and post infusion medication. I think everyone who's using Dlbcl is acquainted to this scheme, whether using oral or IV paracetamol around 1 gram prior to infusion, antihistaminic, diphenhydramine, steroids, oral or IV, 1 hour before DARA infusion at the dose of 40 milligram during cycle 1 and 2, on day 1 of cycle 3 and 4, and at the dose of 20 milligram with subsequent dosing. Of course, we should take into consideration our patients with chronic lung disease or asthma. These are patients that should be approached in a different way. And this is something that we do with our respiratory team, who can help us sometimes to control this issue. Next slide. We should not forget about the interference with the indirect Coombs test. And that's why if we want to ensure that our patient received a timely transfusion, we should type and screen patient prior to starting daratumumab, and we should inform also the blood bank that they will receive a sample from a daratumumab treated patient. Phenotyping may be considered prior to starting daratumumab treatment as per local practice and blood bank guidelines. Next slide. Next slide, please. Okay. So if we want to summarize this, DARA plus VTD is the first phase 3 trial, Darzalex trial in the newly diagnosed multiple myeloma transplant eligible, with a 53%, which is very impressive, 53% reduction in risk of disease progression or death, with minimal toxicity, adding toxicity, with deeper responses at I mentioned, and there's no second chance at a first response. DVT at frontline should provide that remission and with less toxicity and long-term response. So probably based on this data, quadruplets is a new standard of care. We can conclude that it's a new standard of care for newly diagnosed multiple transplant eligible multiple myeloma patient. Next slide. Thank you very much for your attention. I wanted to be straight to the point and brief, and I'm very happy to share your thoughts in the Q&A session. Thank you.
Thank you, Khalid,
Thank you, Dr.
for
Khalid.
this presentation.
So thank you all. Alhamdulillah, as-salama, Dr. Khalid. Dr. Sheikh, I think that we have one question.
One question, yes.
And Dr. Nabil is not with us to ask him some questions about the economics of
It's about,
biosimilars.
It's a question from Dr. Manal Deglawi. And the question for Dr. Khalid, I would like to ask about the differential diagnosis between multiple myeloma with nodal involvement and plasmablastic lymphoma clinically and therapeutically.
Well, hi, Fadi Kifo.
Hi.
Thank you. The question was, تعيده, please.
the diagnosis between multiple myeloma with nodal involvement and plasmablastic lymphoma clinically and therapeutically. Dr. Manal, you can also open the...
Maybe she can ask me the straight question.
I can answer if you want.
Can you open the...
I can answer
I can Jean, I can answer also, but if you want.
Panelist, let Dr. Jean Sheikh
answer.
Jean, answer.
Dr. Jean Sheikh.
No, basically, it's totally different diseases. Multiple myeloma is a clone. The clonal disease, however, with gammopathy, etc., the PBL or plasmoblastic lymphoma is totally rare disease. Yes. With rare expression of CD20, maybe CD138 positive. We have clinical manifestation.
Jean, yes, you're right, Jean. She's asking me. But it's totally different story.
Yes.
The clinical manifestation is totally different.
It's a totally different story. When you see it, Ahmad, خليني بس جاوب. It's a totally different story from the beginning.
Yes.
Yes,
from the beginning.
But plasmablastic lymphoma.
But it's a very good question, Ahmad. It's a very good question because the question states about what the end of the story of the treatment. And I think once we have a patient with the presentation of a so-called myeloma / B-cell lymphoma, you know both of them, of you, that is a totally different story. I think what she's asking, what the doctor is asking, is about what is the difference between approaching patient with a full-blown multiple myeloma or a patient with IgM or all the presentation. I think both of you know better how to do this.
Khalid, the question is, what clear? What is the difference between a PBL and multiple myeloma? PBL is a rare diffuse large B-cell lymphoma, as Jean told us. This is a plasmablastic, which is totally different than monoclonal myeloid.
That's what I'm telling you.
Myeloma cells, they are CD20 frequently negative, 138 positive. This disease was associated to HIV when it was discovered, but not HIV or EBV in the years. And this is a very aggressive disease presented with nodal and particularly gastrointestinal skin and lymph nodes and organ. This is a very bad disease.
The treatment also is totally different.
We have to go beyond R-sharp. That's it. We have to go with targeted therapy like bortezomib, etc.
It's not a multiple myeloma, yeah.
Yes, this is more. This is different, totally different.
Then I will join
genetically and therapeutically.
يعني بس to tell you.
بس I want to tell Ahmed something. I was delighted with your presentation. If I have time a little bit.
Thank you.
Yes.
I was delighted with your presentation.
Thank you.
بس هلا شالي ليش? The questions that I have, you went from the A to Z. I have a very philosophical question. Yeah. Going back to the 15 years ago, when we started to have all this tsunami in the presentation and treatment of, for instance, multiple myeloma, because you were involved first about that, and then CLL and then AML. Why? Having all these changes that we are biologically, we're seeing in large cell lymphoma, why we don't have this tsunami?
يعني in terms of response.
Yes. يعني قديش عندنا هلا؟
لانه
خلينا احمد خلينا لانه في ناس عم تسمعنا. خليني احط شو
دكتور
اللي عم
خالد
بقوله.
دكتور خالد تسلم لي.
إيه.
your questions is clear. انا I think يعني مشان مسألة الوقت
مظبوط.
دكتور أحمد إبراهيم فهم ال questions.
يعني
فأنا-
why
أنا
we didn't
برأيي
obtain
let him answer the question.
yes
Let
why
him-
we didn't obtain a quick changes in the treatment. It is different than لأنه first of all R-CHOP did not show a clinical significant difference over years between R-CHOP and other super CHOP. Then progressively investigators came with the new discovered. يعني discovered is the last 10 years, 10, 15 years, not the last 30 years. And they started to investigate and then to analyze a subgroup. And we arrive now with a lot of information. I think we will have a tsunami. We started to have a tsunami 2-3 years ago, and we'll continue to have it more and probably more rapidly than AML or multiple myeloma. We have to, as you see, I refer you to in the نروح لسن and
حبيبي
and
فهمت
you will
عليك
see
أحمد.
this.
احمد فهمت عليك على الموضوع. انا كنت عم بعمل just comparison between the four things: the acute leukemias, the CLL, the myeloma, and then at one time, we had this, the tsunami of the 2000s with the monoclonal antibody and CHOP, and then شفنا regression about that. Maybe because of the all يعني هالريسبونس اللي كان عندنا اياه. هلا عم نرجع بنسمع شغله جديده in general. هذا هو. عملت لكتشر يعني exceedingly very nice. بس هودي كل الخبريات I think this is something that should come back and come back and come back until this is the future if large cell lymphoma. ما يحق ولا لا؟
excellent. You are totally يعني you are totally right, Dr. Ibrahim. And I think we have to give the micro to our يعني to Dr. Jean Sheikh to see if there is any question, any comment, and then after to close. I think it's time.
صرنا 9:15.
يلا. Thank you, Dr. Jean.
Thank you, Fadi. Thank you, everybody. I want only, we don't have any question on the chat. We reach almost 100 attendees for this meeting, almost 86, 87 attendees and 12 panelists, which is very interesting after this long day. Especially in Beirut, we are living a very big crisis. Tomorrow we have the anniversary of the big explosion of 4 August. So everybody is alerted, and hopefully we will pass this crisis again.
Thank you, John, for mentioning this. Thank you very much.
Thank you, Khalid. And I have only one comment. It's not really a question to the very nice presentation of Ahmad Ibrahim. Ahmad, as you know, in the treatment of Dlbcl, and we already published our experience over 60 patients in clinical leukemia, lymphoma, and myeloma with my fellow Dr. Rula Said, actually working in Canada. We publish our experience in the first line, the Dlbcl, replacing Vindizine by Vincristine in the RACVP protocol, because we don't have Vindizine in Lebanon. As you know, when we do a PET guided, as the Hodgkin lymphoma PET guided therapy in the Dlbcl, if PET2 negative, we can continue RACVP to cycle high dose methotrexate, RIE, and RAC later on.
This is the reason.
Or PET2 is not complete response. We can see if less than 70%, we can go for intensification. I repeat, for young patient less than 60 years old, the 2 years overall survival and PFS is almost 86, 87%. We have a plateau with RACVP and first line. We have a plateau. 90% of the patient in this global and general management of DLBCL, independently from the subtype GC or ABC, can be cured with this strategy. So R-CHOP, I think, is from the past. It's a good regimen for the elderly population, patient non-fit maybe, but RSVP is more toxic, more intensive, but the outcome is much better.
I presented RSVP to our shop and randomized patient with an IPI, and I agree, and I like SVP لأنه I am مثل ما بقولوا طفل من الليزا. فالهيستوري على ليزا. I didn't present is a shift in the slide where G was controlled to compare R-CHOP to Z-CHOP. تحت شو كان فيه؟ كان فيه the same LISA PET drive. I didn't present this for sake of time, but in this study, I agree that, as you mentioned, usage of RSVP and it was interesting in continuing in RSVP protocol is interesting in PET negative patients to Cyprus. I agree with you.
Thank you, Ahmed. I have the last.
If you go,
sorry, I have a suggestion for Sami and Dr. Fadi, both. I suggest for this nice meeting, really a regional meeting, to have a presentation maybe from our fellow, our published study in either in Jordan or Lebanon or in different country, have some specific and dedicated session to present
our experience.
The public, our personal experience, or maybe the study of our fellow and colleague.
We can present in this experience our study, our team regimen instead of BIM. We published, you published, we have local experience and we have to promote our local experience. يعني in France, a multi-center study with team was published. We did 100 patients in shorter time. In the 60 patient in clinical lymphoma myeloma, interesting. We can present our local experience. Exactly.
So thank you
everybody.
Thank you, Dr. Sheikh, for the suggestion, and really we are welcoming this studies اللي نقدم فيها our personal experience. So if you would like to contact or to send the titles of the lectures that you want or the trials that you did, we usually dedicate a session for the juniors, and anytime you are welcome to do it. So to close it,
سامي وفادي عم تسمعوني منيح؟
Yes.
حبيبي أنا I suggest something else. What about doing a session about hematology changes in COVID patients? فكروا فيها خلينا نعملها. يعني it's very important فادي. هذيك المرة حكيت أنا وياك يمكن هذيك المرة هيك. But let's do this. The hematological changes for patients with COVID. It helps everyone.
Okay. نحن usually إذا بيسمح لي البريزيدان دكتور سامي نحن we will be glad to receive any suggestions. هلا there is a question and I think Dr. Jean Sheikh is answering it by typing مش هيك. But the proposal of Dr. Jean, I assure you إنه it will be realized. نحن حنعملها أكيد. We will do a session properly ABC. يعني it's a regional session about the يعني the local experience, بس طبعا with innovation. يعني will not take something that has been done simply data collection. يعني مثل ما عملتوا انتم original studies.
يعني a new approach, a new conditioning, a new approach in driving in PET drive.
يعني we will do it, Dr. Jean will be sharing the session since it is brilliant idea, ونحن كلنا بنشارك فيها إن شاء الله. بس بعتقد نحن we have to يعني to stop the web لأنه تعبت الناس. ودكتور سامي the word is yours. نحن طبعا شهر أغسطس حنرتاح هلا، بس دكتور سامي بيسكر بينهي لنا.
Thank you
very much.
Thank
for
you again for
very
all the
interesting.
speakers. And again, Dr. Khalid, alhamdulillah, as-salame. And just to announce that
Thank you very much, Habibi.
our next activity will be 7th of September and will be about the GI malignancies. Thank you all and see you all soon. في النهاية فقط بتمنى السلامة والأمان للبنان وللبنانيين، وإن شاء الله إنها الأمور بتتحسن وكل أموركم بتكون بألف خير، وشكرا لكم جميعا.
Thank you, Sami. Thank you, Sally, for this.
Thank you. Bye bye.
يعطيكم العافية. Thank you very much.